Hello everyone, my name is Elisa Valentine. I'm a senior here at UNT, and I'm going to be presenting my research on bidirectional associations between depression, insomnia, and pain among nurses. Nurses are particularly likely to experience disruptions in mood and sleep due to stressful work environments. Studies have shown that the prevalence of depression and insomnia in nurses is high. Depression and sleep problems frequently co-occur and may exacerbate one another. Sleep disturbances are one of the key clinical features of depression, and longitudinal studies have shown that depression is a strong predictor of subsequent sleep problems. However, sleep is also a strong predictor of depressed mood. Research supports a strong bidirectional association between depression and insomnia. However, no studies have examined these bidirectional associations in nurses, despite the high prevalence of both conditions in this population. So the prevalence of depression in nurses is approximately 18%. The prevalence of insomnia in nurses is approximately 34%. Depression and insomnia are associated with increased risk for poor health outcomes, such as chronic fatigue, increased medical costs and healthcare utilization, and more physical symptoms. Given the critical role that nurses play in the healthcare system, it's important to understand the causes and consequences of their health and well-being. Sleep and mood disturbances are strongly related. Yet few studies have examined the bidirectional associations between these variables across time, or how these associations may be exacerbated by other factors such as pain. To address this gap, we examined if changes in depression were associated with changes in insomnia across a year, if these associations were stronger for nurses with higher levels of pain at baseline, or if depression and insomnia prospectively predicted each other across a year. In this method section, our procedure is that the nurses were recruited from 2 Dallas hospitals via nursing staff presentations, notification through employee email systems, and flyers that directed them to an initial online consent form. Inclusion criteria is A, not yet received the current season's influenza vaccine, B, between the ages of 18 and 65 years old, and C, registered nurses actively working at least part-time at one of 2 regional hospitals. Exclusion criteria is A, pregnant/nursing or planning to become pregnant, or B, having an egg allergy. The method section about the participants is that there's 461 nurses. The mean age was 39. The participants matched national demographics of nurses in the United States. Most participants were female, 91% of them. They're white, 78%, and non-Hispanic, 90%. A significant portion of the sample also self-reported as Asian, 11%, or African American, 7%. In the methods section, we have the measures that we used. We use the PHQ-9, which is a widely used and well-validated instrument for measuring the severity of depressive symptoms. It consists of 9 items that assess both affective and somatic symptoms related to depression and depressive disorders, with higher scores indicating higher levels of depression. We also use the Insomnia Severity Index, the ISI, which is a 7-item self-report measure that assesses perceived severity of insomnia, like difficulty falling asleep, staying asleep, waking up too early. Each item uses a 4-point Likert type scale from 0 to 4. And lastly, we use the PROMIS pain measures. These 2 items were selected from the PROMIS Pain Intensity Short Form scale. One item asks about participants' pain intensity at its worst in the past 7 days, and other items asked about participants' pain intensity on average in the past 7 days. Both items are related on a 5-point scale of none to very severe. Our statistical analysis plan is we're using simple linear regression. we examined if change in insomnia symptoms across a year is associated with change in depressive symptoms across a year. We also used multiple linear regression. We examined if pain at baseline moderated the association between change in insomnia symptoms and change in depressive symptoms across a year. Using cross-leg panel models, we examined if depression symptoms at baseline predicted insomnia symptoms 11 months later, and if insomnia symptoms at baseline predicted depression symptoms 11 months later. All of these analyses were conducted in the open source statistical program R. Here we have our correlation chart. This chart shows bivariate correlations among all key study variables, and it is displayed in this figure here. Insomnia and depression symptoms were strongly positively associated at both time points. So this result, the association between change in insomnia versus change in depression across a year, the increases in insomnia across a year were associated with increases in depression across a year. And we have this chart that shows the insomnia and depression as a predictor of one another across a year. In cross-legged panel models, depression symptoms at baseline predicted insomnia symptoms 11 months later. But insomnia symptoms at baseline did not predict subsequent depression symptoms. In our summary results, we can conclude that increases in insomnia across a year were associated with increases in depression across a year among nurses. Depression was a stronger predictor of subsequent insomnia than vice versa, and these results are somewhat in contrast to other studies. We found that increases in insomnia across a year were associated with increases in depression across a year. Pain levels at baseline did not moderate this association. In cross-legged panel models, we also found that depression was a stronger predictor of subsequent insomnia than vice versa. These results expand on other studies by examining these associations prospectively across a year in a unique sample of hospital nurses. Together, these results highlight the reinforcing nature of sleep and mood disturbances in nurses and help identify potential targets for cognitive behavioral treatments in this population. The future directions and implications of our study is that depression might be a risk factor for future development of sleep problems in nurses. It may be important to screen nurses with depression for insomnia and vice versa. And it's important to understand causes and consequences of nurses' mental health and well-being. Treating depression may have downstream benefits on improving sleep outcomes. Given the critical role that nurses play in the healthcare system, it's important to understand causes and consequences of their mental health and well-being. Their sleep and mood may impact not only their own health outcomes, but also the ability to provide effective patient care. This slide shows the references that I used for my study. And that is the end of the slide. So thank you very much.